to task with this wonderful talk. Now we have clarified what we need to do for our babies with congenital hypothyroidism. So I think let's now move on to acquired thyroid disease in children and adolescents. I have no disclosures. We'll try and go over quickly over thyroid dysfunction and thyroid nodules. And we'll go over hypothyroidism, hyperthyroidism, and thyroid nodules in a talk one by one. So going on to hypothyroidism. So we all know the classic signs and symptoms of hypothyroidism. I would just emphasize two. One is excessive weight gain in absence of a linear height gain, and in kids who are having a goiter. Other than that, the fatigue, the excessive weight gain with progressive height gain, and all of these things are very non-specific and don't really help us much with the diagnosis. So for your diagnosis, we just need a TSH and a free T4. You can consider sending thyroid antibodies, which are namely two anti-thyroid peroxidase and thyroglobulin antibodies. So I figured I had to be appointed as well. So in that duration of time, but where does it come in? I don't know. Okay, I don't forget it. So the total T3 and free T3 are generally not needed for diagnosis. You can also consider screening for thyroid disease in children who present to you with dyslipidemia, especially elevated LDLs. Again, also in depression, when especially you have a condition where somebody is not growing well, and this is again for prepubertal and during puberty. Thyroid ultrasound again is not really indicated unless you have a specific concern. If you palpate the gland and you see a nodule or it's asymmetric, only then in those conditions for hypothyroidism would you go ahead and obtain an ultrasound. This is the list of common etiological diagnoses of hypoglycemia. Of course, on the top of the list is autoimmune. Again, we have to think more of the autoimmune diseases in context of diseases like type 1 diabetes, juvenile rheumatoid arthritis, and Down syndrome. Iodine deficiency remains unfortunately the worldwide most important cause. We are eliminated in developed countries with having iodinated salt, so somebody who is not using them is still at risk in the US. The other, again, delayed presentation of congenital causes. As a thyroid presentation, you have to remember the interaction with medicines, lithium being a notorious one, amiodarone being a lot in our CVICU with all these cardiac hits. Hemangiomas as well, because you have the overexpression of type 3 deiodinase, which converts your T4 to T3. And we'll talk in a minute about the central hypothyroidism because we have to be really careful when we start treating them. Treatment-wise, again, these guidelines are coming from American Thyroid Association guidelines for hypothyroidism from 2014 guidelines. They're not any recent ones. So they indicate that levothyroxine remains the standard of care. T3 is not well studied in adult and is definitely not recommended in kids. There is no role of having dietary supplements, nutraceuticals, or over-the-counter products. The only element I would say is indicated is selenium because few of the thyroid enzymes are actually selenoproteins, so there might be some role of selenium, again, not really studied well in kids. Goal of treatment is a symptomatic resolution, of course we want, but also normalization of the thyroid function. Again, ATA specifically, and I quote from the ATA guidelines, symptoms alone lack sensitivity and specificity and therefore are not recommended for judging adequacy of treatment. So you go by what your thyroid function says, your lab values say. The clinical indicator that you can still follow is going to be catch-up for growth in height and, of course, proportionate weight gain. Once you initiate somebody on levothyroxine or you are changing the dose, they recommend doing TSH and free T4 for assessing the adequacy of your dose in about 4 to 8 weeks. And a lot of times, as our community pediatricians, we ask you for help because a lot of our kids travel 2 hours, 3 hours to see us. We do not want them coming back for lab draw, and we really appreciate their help in getting those TFTs done and getting them sent to us. Again, there's some people who prefer brand name levothyroxine called Synthroid versus generic medication. ATA says that it's not really any different, that you prescribe somebody with generic versus brand name, but what do they recommend is that if you're switching somebody from generic to a brand name Synthroid or vice versa, you go ahead and repeat the thyroid function one more time, because even within FDA, they're allowed to have that 10 to 15% variation in the amount of actual medicine. So that is something to remember. If somebody presses you for Synthroid, I go ahead and prescribe it. If insurance covers it, go for it. One slide about the subclinical hypothyroidism. So we have all these patients that we see with TSHs of 5 to 10, and we usually do not treat them unless there is a concern like somebody with Down syndrome, somebody with type 1, who has autoimmune disease. We worry about their progression, so we'll go ahead and start treating them. There was an interesting study that came out just in 2019, about a couple of months ago, in Journal of Endocrine Society, which is one of our premier journals, and it was very interesting that it said that TSH of 11 was the one where a repeat value would be still above 10 and you would treat. The main predictors of treatment were actually the antibody status and the thyroid exam findings, not specifically a TSH between 5 to 10. And I know we frustrate a lot of our patients with this, that you don't really need treatment, this is a gray zone. So this study confirms that as well. One point about obesity, so there is no role of levothyroxine treatment in euthyroid individuals. And obesity in itself can lead to increase in TSH, so that gray zone between 5 to 10 can still happen in obesity, and usually will come back down to normal with weight loss. So this is what I was talking about, the central hypothyroidism. So if you have somebody who has a low or normal TSH in context of low T4, be very careful. This could be a central hypothyroid kid and not your routine primary hypothyroidism. Central hypothyroidism meaning the defect is at the level of pituitary. So more often than not, it's an error of assay. So most of the T4s that we send routinely are immunoassays. So you can repeat free T4 by another assay. Usually we end up sending by something called an equilibrium dialysis, which is a gold standard method, and usually will tell you one way or the other what it is. If you really still think that this is central hypothyroidism, then you need to assess other hormone pituitary function, because it's very uncommon for somebody to have central hypothyroidism in isolation. Central hypothyroidism is a few words, it's more subtle in onset. We might need MRI, and then we can do some TRH stimulation testing, which we don't routinely follow anymore. No, all right. We're good? Okay, so I'll slow down. Coming on to hyperthyroidism. So again, we know that weight loss, tremory, jittery, shaky, high blood pressure, palpitations are all our signs and symptoms of hyperthyroidism. These kids may or may not have a goiter again. Just a reminder that if you find a child with hyperthyroidism in your practice, we are always on call, always please reach out to us. We want to see these kids within 4 to 6 weeks. We will recommend initiating treatment to you guys, of course, but we want to see these guys in our clinic ASAP. If you are thinking of somebody going to thyroid storm, which will be if they have fever, if they have altered mental status, it actually becomes a medical emergency. The kids head straight to the local ER. I will not say that you send them to children straight. I want them to go to the local ER, get their baseline treatment started, and then being transferred to children's as needed. Labs-wise, again, we'll do our TSH free T4 as usual, and here we add on a total T3. A lot of places will do a free T3. We usually do not do it because T3 has a very short half-life and may or may not present the true status of the thyroid disease. We can check for thyroid antibodies, the previous ones that we talked about, and also something called thyroid-stimulating immunoglobulins. These are, if they are positive, they kind of indicate Graves' disease. If you do not have TSI that you can do, you can measure something called thyroid receptor antibodies. So thyroid receptor antibodies are a combination of thyroid-stimulating immunoglobulins and thyroid blocking antibodies. So depending on what the clinical status is, you will, if they are in a hyperthyroid phase, you will assume that most of these thyroid receptor antibodies are stimulating ones. You will consider doing a CBC and a chemistry, of course, before you initiate treatment, because we want to monitor baseline treatment for starting methimazole. You can consider doing an ultrasound and a radioiodine uptake as indicated. Not in all cases, this will ultrasound and radioactive iodine uptake may or may not be the deciding factor before you start treatment, especially if somebody is really hyperthyroid and you're worried that they might end up in thyroid storm. The thyroid storm is very uncommon in kids, but again, kids don't read books and come, so there is that. So I know this is a very busy slide. I took it, I have the reference right there. And it kind of guides you through the process and thinking about the causes of hyperthyroidism, so we can decide them as increased secretion of thyroid hormone itself. So the classic one that we all know is Graves' disease, where you have the antibodies against the thyroid which stimulate the thyroid gland. You can have a symmetric non-tender goiter, you have antibodies positive, and the if you do an uptake scan, they will be diffusely increased. You can have a toxic multinodular goiter where there's an autonomous production of thyroid hormone, and once you sonogram them, you will find multiple nodules. The antibodies in this situation will be negative, and there will be multiple foci of uptake on the uptake scan. If you have a toxic adenoma, so there's a specific nodule that is hyperfunctioning, you will find a single nodule on thyroid exam. May or may not find it actually. Antibody status is going to be negative, and you do an uptake scan, you will find a single focus. And this becomes really relevant to find what is the cause of hyperthyroidism, because it guides on to the ultimate management as to how we're going to do it. One word about something called Hashimoto's. So this is an excess secretion of the preformed thyroid hormone. So you can imagine Hashimoto's thyroiditis or an acquired hypothyroidism. When there is an acute destruction of the gland happening, then there is excess secretion of the preformed thyroid hormone, and you will end up getting a hyperthyroid phase. In this situation, if you do an uptake scan, your uptake is going to be actually low. You can have subacute thyroiditis, which is again viral in etiology, and there is a release of preformed hormones. You can have a painful goiter. Antibodies are negative. Uptake scan is decreased. If you do an uptake scan, the uptake is decreased, and usually this will not require treatment. This is more symptomatic Talon Motrin kind of treatment. But then you can have also bacterial thyroiditis, in which it's very hard to differentiate at the very onset. So I won't go against you if you start antibiotics on somebody. Remember about, again, drug-induced hyperthyroidism. We talked about imidrone. There's also going to be if somebody takes excessive iodine. Am I on time? Okay. All right. So this is just focusing on treatment of Graves' disease. And again, we can try three things. We have our medicines, we have radioactive iodine, we have surgery. As pediatricians, we always start with anti-thyroid drugs. I have rarely had a child who straight away wants radioactive iodine or surgery. These are the indications and contraindications that's listed. To remind you, so once we start somebody on methimazole, the major adverse reaction is agranulocytosis. So we always counsel our kids in the clinic and families in the clinic that if you ever have fever or sore throat, stop your methimazole, go to the local urgent care PCP's office and get your CPC checked, because if your ANC and absolute neutrophil count is low, then you want to stop your methimazole for a while. Radioactive iodine, again, specific kids, not all the time. It also depends on what the family wants. Sometimes they get really scared of radioactive iodine, but I think it's a good way of treating it and making them hypothyroid, especially if they're having medication side effects. There was a recent paper that came out in JAMA about how radioactive iodine can cause increased risk of cancer, but there's already a lot of claims against it, and that how the study was not, the data was not assessed properly and things like these. So it's still an indicated treatment, but as their doctors, we are supposed to counsel them for all the benefits and side effects of all these medicines. Surgery, again, an option, but we of course want to make them clinically euthyroid before we proceed for surgery. Radioactive iodine is also contraindicated if you have Graves' eye disease. Coming on to thyroid nodule. So thyroid nodule in kids is very different from adult nodules in the sense that it is less common, but unfortunately more malignant. And they are more likely to have regional lymph node involvement, extrathyroidal extension, and pulmonary mets. But the good thing is they overall have a favorable prognosis. So a lot of times when somebody hears the word cancer, a thyroid nodule, everybody gets frustrated. So I have to tell them, good, there's a very good prognosis. Unlike all other cancers, the child will not have to go through chemotherapy and all the side effects of chemotherapy, that you're having bone pain, there's hair loss and all of those things going on that don't happen in thyroid. So it is way different from your routine cancers, and fortunately it's one of the cancers that we follow. Children who have differentiated thyroid cancer, again, this is an ATA guideline, should be cared for. Team of physicians experienced in the management. So the good thing is that because it is slow progression, we want to take time to identify and refer these kids, get them appropriate diagnosis, and so we can go ahead and plan treatment. We are establishing a thyroid center at Children's, where we have endocrine, ENT, radiology, nuclear medicine, and lots of other specialties joining us and helping out as needed for our thyroid program. We do have our twice a month or 3 times a month, every 3-month meetings and discussing cases. There's a lot of feedback going through back and forth. So if you are ever concerned, you can still reach out and we will help you as best as we can. A lot of these teenager kids were previously going to UMS, so we are trying to establish care because all the other care is at Children's, and Children's being a trusted name, we want to continue that. These are recommendations from ATA 2015 guidelines. These are pediatric guidelines. They are working on 2020 guidelines, but they are not released as yet. So I will go over what the 2015 guidelines say. They say that an annual physical examination of the thyroid in children is indicated, and additional imaging should be pursued if you find something abnormal. In children who have radiation exposure, routine screening is up in the air. You can decide one way or the other. We do not have clear data to indicate either. And again, children who are in pre-risk or family cancer should be sent to a specialist center which can handle these kids. Again, in terms of thyroid surgery as well, if you're operating on these kids, they want it to be a place where there's a high volume thyroid surgeon who is doing about 20 to 30 thyroid surgeries per year. So you can imagine we want to consolidate where we do these surgeries so that one person can get all the experience. If you have a patient with autoimmune thyroiditis and you're worried about a thyroid nodule, even in those situations, you want to do an ultrasound with an experienced sonographer, because the sonogram makes a whole difference about what your initial thought process is and how we do pursue it. The evaluation and treatment of thyroid nodules should be the same as adults as in children, except that we want all FNA to be done under ultrasound guidance. I have been with Dr. Portener at UMS, who does his thyroid he is the endocrinologist who does most of the thyroid stuff there. He also performs under ultrasound guidance. Ultrasound characteristics in clinical context should be used rather than size alone. So in a lot of adult guidelines, you will talk about that a size has to be about a centimeter or 1.5 centimeter to proceed with FNA. In children, the size does not matter. It is limited by the person who's doing the biopsy, which for us is interventional radiology. If you have a hyperfunctioning nodule, so we talked about a toxic adenoma earlier in hyperthyroidism, where you have a nodule which is hyperfunctioning. Usually if you're going to remove that, and the current guidelines do say that you should remove that, the FNA is not generally indicated. You should, if there is always a possibility that there is a diffusely infiltrative form of papillary thyroid cancer, and surgery. So basically lobectomy and estomectomy is favored over repeat FNA if you have an equivocal cytology. This guideline, this slide again is from the ATA 2015 guidelines, which goes over how you would proceed with somebody with thyroid nodule. We are more than happy to answer any question that you have over the phone that you have a suspected thyroid nodule, but this is what the guidelines usually will say, that if you have a solitary or a suspicious thyroid nodule, go ahead and get your thyroid test. If the TSH is suppressed, proceed to an uptake scan, because you want to see if this is a toxic multinodal correlator or it's just a single nodule that is hyperfunctioning. If you do find that, then you go ahead and proceed with surgery. And surgery being at this point, you will probably do just the globectomy and the ischemectomy. Once the FNA comes back, you can proceed. And if it is a malignant, then you'll go for completion thyroidectomy. If the TSH is not suppressed, you can go for FNA under ultrasound guidelines, and then proceed according. If it is benign, then you just repeat the ultrasounds, and so on and so forth. And if it is inadequate or non-diagnostic, you can do the repeat ultrasound and FNA, or if the family is concerned, you can take that nodule out and then proceed with the FNA. That's my talk about it. I went very fast, so I'm sorry about it, but I had limited time, but we'll be happy to have your questions at the end. Thank you. I think Dr. Oden is going to talk next. Let's talk about obesity.